So hello everyone, my name is Dr. Hiran Sivaraj and I'm the co-founder of the OncoShot Cancer Collaborative Platform. And on behalf of my panel of speakers here today, I'd like to thank you all for joining us in this webinar. I'd like to share that today's session is actually organized by the Breast Cancer Foundation and the OncoShot Cancer Collaborative Platform. We are also very appreciative of the support from Roche for their sponsorship. This has enabled us to reach out to the patients and healthcare communities, as well as members of public biosocial media. Now, today's session is going to be all about breast cancer, and we will be exploring some broad but very important points in relation to diagnosis, management, and support. The webinar will start with a presentation covering broad and useful information about breast cancer. And following that, we will move to a Q&A session where we'll be addressing many of the questions which you have shared with us at the time of registration. Now, to keep things also a bit more engaging, we will be sharing some short and useful slides during the panel Q&A. And during the panel Q&A, and this session will be recorded as well for your benefit and sent to you later after the webinar. Now, I'd like to introduce our esteemed speakers for today. Firstly, I'd like to introduce Dr. Wong Nam Soon. He is a senior medical oncologist who is currently practicing at OncoCare Cancer Center. Dr. Wong was also previously the Chief of Breast Cancer in the Department of Medical Oncology at the National Cancer Center, Singapore. His subspecialty interests includes both breast and gastrointestinal cancers. Dr. Wong will be our keynote speaker today with his presentation on broad principles of breast cancer diagnosis and management. Thank you, Dr. Wong, for being here with us. We also have with us a very familiar person, Dr. Jolin Lim, whom some of you may fondly recall from our previous webinar. He's a consultant and clinician scientist based at the National Cancer Institute, Singapore. Her primary clinical and research interests are in breast oncology and early phase clinical trials. Dr. Lim is actively involved in several multi-centered international clinical trials and is well published in leading peer-reviewed journals. We look forward to her sharings during our Q&A session, as well as some insights that she will be providing into recent developments and evolving studies in the Singapore landscape, and this will be of benefit to many of us. Now, I'm also very happy that our panel will also include Ms. Samantha Sia from the Breast Cancer Foundation. Samantha is the General Manager of the Breast Cancer Foundation and is a passionate advocate for welfare and upliftment of breast cancer patients and survivors. Now, I was introduced to Samantha and the leadership team of the Breast Cancer Foundation and was inspired by the efforts that they have taken to provide an added dimension of support for the well-being of our breast cancer community. Now, Samantha will be sharing the important activities being conducted by the BCF, and it is our hope that some of you may directly benefit from the tools and services that Samantha will be sharing later in the webinar. Now, without any further delay, I'd like to call upon Dr. Wong to give us his presentation. Thank you.
Hi. A very good morning to everyone. I hope you can hear me well. Yeah, so welcome to the webinar. It's my pleasure to be here, and thank you for the kind invitation. So today I'll be covering in a short 15 minutes broad principles of breast cancer diagnosis and management. So during this talk, I hope to cover some of the common questions that patients may have. How common is breast cancer? How is it diagnosed? What are the systemic therapies available to treat breast cancer? And very importantly, how do we prevent and screen for breast cancer? And I'll make some concluding remarks. So breast cancer is the commonest cancer among women. It accounts for 1/3 of malignancies in women. In 2018, the estimated number of cases in Singapore was 3,136, compared to a global incidence of about 2 million. The lifetime risk of developing breast cancer is about 6 to 7%. Now, what is breast cancer? So breast cancer is a malignancy arising from the lobules and ducts of the breast. So the cells in these structures have developed the ability to proliferate out of control, to evade cell death, and to eventually invade and spread to both surrounding structures and distant structures. So the earliest sign of breast cancer, we hope that it will be a mammographic finding rather than an actual symptom, because usually during mammographic finding is diagnosed at an earlier stage. So earlier stage of breast cancer, it can also present as a breast lump, and subsequently, as the cancer progresses, the tumor may spread to the surrounding lymph nodes, leading to a lump in the neck or under the armpit. And sometimes the skin overlying the cancer can become inflamed. So this can lead to skin changes, and also there could be disturbances to the nipple shape and structure. In a more advanced stage, during metastasis, patients can develop bone pain. The tumor spread into the lungs can lead to shortness of breath, and weight loss is a very advanced symptom of breast cancer. Now, in diagnosis, we rely on imaging as our first step, but ultimately histology is required to confirm breast cancer. A few take-home messages about imaging is that mammography can miss about 15% of breast cancers. And even for breast ultrasound, which is highly sensitive and often used as an adjunct to mammography to determine whether the lump is solid or cystic, a normal finding cannot replace the further investigation and even biopsy if there are suspicious clinical findings. MRI breast is not very commonly used. We use it in special situations. The advantage of MRI is that it is extremely sensitive. And so we're talking about more than 95% sensitivity. But unfortunately, even normal breast structures can enhance. So it has low specificity. So we reserve the use of MRI breast in special situations where, for example, the clinical extent of the tumor is larger than that of what we can see on routine mammogram and ultrasound. Or for example, in patients who are mutation carriers, who have a high risk of breast cancer on the opposite breast, which could be missed by mammography and ultrasound. So histology is the most important step in terms of breast cancer diagnosis. We need to confirm that the cells are indeed cancerous, and we need to obtain a sufficient amount of material to determine the hormone receptor status and the HER2 status to subtype breast cancer. So this leads into the very important point that breast cancer is not one disease. Even under the light microscope, we can see that the tumor cells can appear as ductal, lobular, medullary, and so on. So ductal and lobular together account for more than 90% of breast cancers. But more importantly, we are now looking at breast cancers at the molecular level. So it's been a long time that we have classified breast cancers into genomic subtypes. And the future is, of course, looking at the metabolic subtype, the protein subtypes, and so on. But way back in the early 2000s, 19 years ago, we already could classify patients into broad molecular subtypes. And then each of these subtypes actually have their own natural history. And here you can see that the luminal A right on top has the best survival. And independent of treatment, you can see that the basal-like subtype and the HER2 positive subtypes have a worse survival. So in the clinic, we don't have access to these molecular tools routinely, but we have simple immunohistochemical stains that can be used to classify patients into three broad categories. So the hormone receptor positive categories, so you can see hormone receptor positive cancer cells staining brown with the special stains, and also the HER2 positive subtype of breast cancer patients. And a small proportion of patients are triple negative. They do not express hormone receptors or HER2 receptors. So when it comes to actually treating breast cancer, I've highlighted here in red that surgery is, as of 2020, the most important step towards cure. And so although we can give systemic therapy and radiotherapy, nothing can at the moment take the place of surgical removal of the primary tumor. After surgery, we provide adjuvant therapy, whether it's chemotherapy, hormonal therapy, anti-HER2 therapy, or radiotherapy to reduce the risk of recurrence. Sometimes we switch the order around. We may need to shrink the tumor with systemic therapy before surgery can be performed. And this is often followed by adjuvant radiotherapy. So special situations where we use preoperative systemic therapy would be, for example, if we need surgical downstaging where the surgeon cannot achieve clear margins, and also we're desiring to reduce the risk of having lymph node positivity and axillary clearance by shrinking the tumor before surgery. And of course, this is increasingly being used as a research tool for us to discover more about breast cancer biology and how cancers respond to systemic therapy before they are removed from the body. So in terms of systemic therapy, these are the broad classes. We use endocrine or hormonal therapy in hormone receptor positive breast cancer. The common question we get from patients is, they hear that hormones can lead to breast cancer, and why are we using hormonal therapy? But these are actually anti-hormonal treatments. We use medications that antagonize the hormones and hormone receptors. Yeah? And then moving on, there's systemic chemotherapy, anti-HER2 therapy, and in the past few years, immunotherapy has come to the forefront even for breast cancer. So what is endocrine therapy? So this is therapy that we use to target the estrogen receptor within the cancer cell. So in premenopausal women, the source of hormones would be from the ovaries, and the stimulation for the ovary to produce estrogen comes from the brain, from the hypothalamus, as well as the pituitary gland. So in premenopausal women, we can reduce hormone output by either surgical or radiotherapeutic removal or damage to the ovaries, or we can inject hormonal therapy to reduce the stimulation for the ovarian function to produce estrogens. In postmenopausal women, where the ovaries are no longer producing estrogens, the primary source of estrogens would come from muscle and fat conversion of adrenal male hormones called androgens into female hormones. And we have drugs called aromatase inhibitors, which can inhibit this conversion of male hormones to estrogens within the postmenopausal female. So once estrogens are produced and they are circulating in the blood, these molecules can bind to estrogen receptors within breast cancers, leading to activation of genes that result in tumor proliferation and survival. And so another way to target estrogen receptor is to actually have an antagonist that prevents binding of estrogens to the receptor, or a drug called fulvestrant, which can actually downregulate or destroy these receptors within the tumor cell. So a few brief words about endocrine therapy in hormone receptor positive breast cancers. So about 80% of breast cancers are hormone receptor positive, and so we use endocrine therapy extensively. So in early stage breast cancer, in general, the drugs that we use are tamoxifen or aromatase inhibitors, or a combination of the two. And in general, we can say that these treatments help to halve the risk of recurrence. In selected premenopausal women, doctors sometimes have to suppress ovarian function through surgery or through injections. So these are patients who remain premenopausal despite chemotherapy, and that has been associated with a higher risk of recurrence. In the advanced breast cancer setting, we know in general that aromatase inhibitors are more active than tamoxifen. These drugs provide longer disease control. We also have data to show that fulvestrant is more active than aromatase inhibitors in the first-line setting. And what has been really exciting in the field of endocrine therapy for advanced breast cancer has been the arrival of CDK4/6 inhibitors, which when combined with hormonal therapy has been shown to provide a survival benefit. So what are CDK4/6 inhibitors? So we know that in tumor cells that have become insensitive to hormonal therapy, the cell cycle is dysregulated, and tumor cells continue to cycle within a cell cycle and to divide and proliferate. So CDK4/6 inhibitors are drugs which inhibit the central enzyme required for this cell cycle to occur within hormone receptor positive hormone resistant breast cancers. And this is just an example of a study called the Modalities 3, which shows that when a CDK4/6 inhibitor, ribociclib, is added to hormonal therapy, there was an improvement in overall survival for these patients. So when hormonal therapy is not used, we use chemotherapy sometimes, or we can also combine, for example, in the adjuvant setting, we add chemotherapy. We prescribe chemotherapy followed by hormonal therapy for some patients. So these are some of the commonly used drugs for breast cancer. So what is highlighted here in red are the drugs that we use in early stage breast cancer. And the drugs here in black, these are the drugs that are used in patients with advanced breast cancer. So they have different mechanisms of actions. They generally act by stopping DNA production or cell division. So I think a lot of patients have experienced or have a lot of the general public has heard a lot about chemotherapy toxicities. So just focusing on the portions in red, you can see that some of the commonly used drugs we use in early stage breast cancer can cause nausea, hair loss, and also numbness of the fingers and toes. More specifically, some of these drugs may be, for example, associated with a small risk of heart muscle injury and leukemia, and sometimes fluid retention and so on. So it is not surprising that both patients and doctors, we have an interest in limiting the use of these medications to patients who really require them. So when we use adjuvant chemotherapy in early stage breast cancer, we provide these drugs after surgery to remove or clear or cut tumor spread and to prevent recurrence and improve survival. On the average, when we use adjuvant chemotherapy, we can observe a 1/3 reduction in the risk of recurrence. So, and we use we select for patients who require adjuvant chemotherapy using clinical parameters. For example, whether the tumor has involved lymph nodes, whether the tumor is of a certain size, whether it looks aggressive under the microscope, and whether there's tumor invasion into the lymphatics and blood vessels, and also looking at HER2 expression. But what has been happening in the past decade has been an interest in using gene expression, multi-gene platforms to determine the risk of recurrence. And what has been a major success, I think, in the past decade has been the ability to validate, to confirm that these gene expression platforms are indeed accurate, they're reliable. So for example, this is a particular platform that's called Oncotype DX, which looks at the expression of various genes within the breast cancer cells, and is able to come out with a composite score, a recurrence score, which not only predicts the risk of tumor spread with hormonal therapy alone, but also is able to predict the amount of benefit that we can expect to see when we add chemotherapy to hormonal therapy. So you can see here on the right-hand panel that this is the results from patients with a recurrence score less than 26. In general, combining both younger and older women, we see that in patients in the subgroup, there's absolutely no difference in the risk of distant spread between hormonal therapy alone in the dashed black line versus adding chemotherapy to hormonal therapy in the orange line. And this has allowed us to spare 80% of patients with hormone receptor positive, node negative breast cancers under 5 cm from having to get adjuvant chemotherapy. So moving on to the next portion, HER2 positive breast cancers account for about 20% of all breast cancers. And traditionally, these tumors were viewed to have very aggressive biology, very high chance of recurrence. But now we have an armamentarium with a huge number of drugs that we can use to target HER2 positive breast cancer. And we have actually turned the natural history around to the extent that we're actually able to observe equal, if not better, survival for patients who have HER2 positive early stage breast cancer compared to non-HER2 subtypes. So the drugs we use can be large antibodies, and these are some of the names, or they can be small molecules that target the HER2 receptor. So we've known for a long time that HER2 positivity increases the risk of recurrence, even for small lymph node negative breast cancers. And this is a picture showing the HER2 gene that has been amplified in HER2 positive breast cancers. So what does HER2 do? So HER2 is a protein on the cell surface of the cancer, and when it is present in excess, there is what we call a pairing of these HER2 receptors and activation of pathways that lead to tumor proliferation and survival, and leads to aggressive clinical history, clinical behavior. So Trastuzumab is a drug that has been designed to attach to the HER2, leading to inhibition of this tumor protein. And in the adjuvant setting, multiple trials have been done showing that on the average, there's a 1/3 reduction in the risk of death when we add Trastuzumab to chemotherapy in early breast cancers that are HER2 positive. Right? So a newer generation form of anti-HER2 antibody has also been developed, which binds to a different part of HER2 compared to Trastuzumab, and leads to, it prevents crosstalk between HER2 and other members of the epidermal growth factor receptor family. It has had a modest success when we use it in early stage breast cancers when added to Trastuzumab, a small 3% improvement in outcomes. But when we use it in the first-line metastatic setting, that's when we really see a huge improvement in survival. If we look at historical controls, advanced HER2-positive breast cancers used to have a survival of 25 months, and this has been vastly improved with the use of this new antibody. So other drugs are also available. So this is a drug that many patients and relatives may have come across in recent years. So Kadcyla, or what we call TDM1 commonly, is a trastuzumab molecule that acts like a Trojan horse. It carries highly potent chemotherapy into HER2-positive breast cancer cells, and in that way, it spares the surrounding tissues from damage caused by the chemotherapy. So this drug has been shown to provide a survival benefit in patients who have HER2-positive breast cancers resistant to trastuzumab. And very interestingly, in recent years, it has also been found to be a useful adjuvant therapy. So patients who have proven to be resistant to Herceptin, when Herceptin is given before surgery, we now offer TDM1 after surgery to prevent the risk of recurrence. Lastly, in terms of therapeutics, I'll talk about triple-negative breast cancer, which accounts for 10% of breast cancers. And these drugs, being negative for hormone receptors and HER2 receptors, they can only be treated with chemotherapy as the main backbone. And these are some of the drugs we use in early stage triple-negative breast cancer, including anthracyclines, taxanes, and platinums. In the advanced breast cancer setting, triple-negative breast cancer setting, there are some specific drugs that we can use. For example, PARP inhibitors in triple-negative breast cancers with germline BRCA mutations. So PARP inhibitors essentially lead to DNA strand breaks within the tumor, and tumor cells with germline BRCA mutations have problems repairing such DNA damage, and therefore they are exclusively sensitive to these inhibitors. Immunotherapy is something very new for triple-negative breast cancers. It's been around for some time to treat other types of breast cancers, but now we're starting to see a benefit within this subcategory of breast cancers. So this is a slide showing how immunotherapy works. And so what you can see here on the left-hand panel is how the immune cells, the CD8 positive T cells, are actually inhibited by tumor ligands called PD-L1. So when tumor cells express PD-L1, they become sort of invisible to the immune cells. And so that allows the tumor cells to evade the immune system. And this interaction can be inhibited by various drugs such as nivolumab, pembrolizumab, and also PD-L1 inhibitors such as atezolizumab. And on the right-hand panel, what you see is an example of a clinical trial adding an immune therapy drug to chemotherapy. And in patients who express the biomarker PD-L1 positive population, you can see a significant improvement in overall survival. And this is in contrast, so a 25-month average survival, you can see, is in contrast to what we saw a decade ago, where patients had approximately a 1-year survival when there was advanced triple-negative breast cancer. So in the remaining few minutes, I'll just touch briefly on how to prevent breast cancer and how we screen for early stage breast cancer. So there are many myths out there, I think, about what can cause breast cancer and what can prevent breast cancer. The maneuvers or the things that are more evidence-based, where there's been sufficient research, would be breastfeeding. Right? So it's been shown that prolonged breastfeeding can reduce the risk of developing breast cancer. We do have medications which have been systematically studied to prevent breast cancer, but these are reserved for high-risk women whom we identify to have a high risk of developing breast cancer, such as patients with precancerous lesions in the breast. And for patients who have the highest risk of developing cancer, patients with BRCA mutations, we can offer risk-reducing surgeries before the onset of cancer. So from a day-to-day sort of life point of view, this is a very sort of a comprehensive table from the World Cancer Research Agency. And you can see that for breast cancer, you can see that it's actually a blank, so there are a lot of foods that people purport could prevent breast cancer, could be beneficial, but unfortunately for breast cancer, many of these foods do not have sufficient data in terms of breast cancer prevention. We do know that alcohol does increase the risk of developing breast cancer, and also sedentary lifestyle, postmenopausal weight gain, these can increase the risk of breast cancer. So what we can do from a day-to-day living point of view would be, of course, avoiding alcohol, doing exercise, being active, avoiding excessive weight gain. For screening, I think mammography remains the most important tool we have for the early detection of breast cancer. So this involves taking an X-ray of the compressed breast tissue, and you can see here the benefits and harms. So on the average, mammography can reduce the risk of breast cancer death by about 1/5. And you can see here in this table that the benefit gets larger with increasing age, and so does the risk of developing breast cancer. Right? So it's not surprising to see that the number of lives saved by screening 1,000 women over 10 years, the benefit increases from the age of 40 and all the way up to the age of 60. The downside of mammography would be the high incidence of false positive mammograms, which may require biopsies to clarify if the findings are true. But given the overall balance, it is still a very, very useful tool for us to allow early detection and to save lives. So it's not surprising then that worldwide there have been guidelines to support the use of screening mammography. There's universal acceptance of mammography for women who are above the age of 50, exactly because this is a subgroup of women with a higher risk of breast cancer and the higher sensitivity in terms of detection of cancers. For age 40 to 49, there's some controversy, and there's also controversy about whether screening should be done yearly or every 2 years. There are many modalities that can be used as adjuncts to mammography. So breast MRI is, of course, highly sensitive, but as mentioned earlier on, there's very, very low specificity. There's a high chance of getting a false positive scan. So we use it predominantly in patients with familial breast cancer. They have germline mutations that greatly increases the risk of breast cancer. And in this situation, breast MRI has been proven to increase the detection rate to an extent which is far superior to mammography and ultrasound. Digital mammography involves obtaining like a tree, basically using digital techniques to enhance the views that the radiologist can obtain from mammography. And it has been shown to increase a detection rate of breast cancer, and it's a useful adjunct for patients with increased breast density. What about breast ultrasound? So we get a lot of questions about whether breast ultrasound should replace mammography. So unfortunately, there has not been large studies to show an improvement in breast cancer survival when we use breast ultrasound as a screening tool. The biggest downside of mammography is that of breast ultrasound is that although we increase the detection rate of cancer, so on average we detect 4.2 more cancers compared to mammography alone when we add ultrasound, but we're also greatly increasing the false positive or biopsy rate. So we're increasing it to 52 per 1,000 cases screened. So at the moment, it is not standard to add ultrasound to screening mammography for everyone. Tomosynthesis is essentially taking a three-dimensional sort of image of the breast. So there have been studies to show an incremental cancer detection rate and then with an acceptable false positive rate. So it's something that we consider in women with high breast densities where lesions may be harder to spot on routine mammography. So in conclusion, We have had major success in identifying patients who do not need adjuvant chemotherapy for early stage breast cancer. And because of personalized medicine, we are able to improve overall survival in our various subtypes of advanced breast cancers. And there's, of course, a need to emphasize that breast cancer screening continues to have an important role in improving breast cancer survival for all our patients and should be advocated. So thank you very much for your attention.
Thank you, Dr. Wong. Yeah, really appreciate that comprehensive overview that you've given us today. In that presentation alone, I think patients with different profiles of breast cancer would find something that's relevant for themselves in terms of how to approach their treatment and what to look out for, in the landscape of therapies as well. In the interest of time, what I'd like to do is we can have participants actually ask their questions on the Q&A. Dr. Wong and Dr. Jolene will be helping to answer some of these questions. But I'd also like to just move on to the next part of the section of the webinar, which is our Q&A panel session. I will be doing some small sessions, presentations by both the speakers, Dr. Jolene and Mr. Manthesia. I'd like to just get Dr. Jolene first to help us go through some new innovations in breast cancer management and therapies, particularly to look at things that may actually help patients in their journey with treatment, and especially there were some questions that were raised about side effects like hair loss. Are there new potential interventions that could help patients with hair loss? And I think the important set of questions was also in terms of how we can look forward into the future in terms of potentially innovative and helpful clinical trials that may actually change the landscape of options for our patients. So without further delay, Jolene, I would appreciate it if you could bring us through your presentation as well.
Hi everyone, I'm just going to share a few slides here, basically to share about hair loss, and of course also about what new treatment options there may be for patients who may not have done so well on standard treatment and may feel like there are limited options left. So I think the first thing that we would like to share with you about is scalp cooling. I think that we have done very well in terms of managing patients' side effects, trying to improve their survival, decrease the chance of relapse, and there comes a point where we also want to take care of the well-being of the patients. And I think a very common side effect that really affects a lot of our patients is actually hair loss. It's something very visual. It's something that they immediately notice when they look into the mirror. It's something that a lot of friends or even people would look at them, because it is not common for women to have complete hair loss unless they are undergoing some form of treatment. So I think that this has been something that has been brought up many times, and we have had patients who actually also felt psychologically that it was difficult to undergo chemotherapy because of the fear of hair loss. And over the past decade and two, there has been a lot of research going on about scalp cooling. I think it is definitely work in progress. We have had more success in some types of chemotherapy than others, but I think it is great that we have an option currently for patients who are undergoing chemotherapy who may want to reduce the chances of their hair loss, that scalp cooling may be something they would like to consider. So how does scalp cooling actually work? It is actually a cold cap that is actually administered and worn on the head. And it has undergone many iterations. When it first started, it was literally a cold cap that was put in the freezer, that was brought out and put onto the head. And then it would be exchanged with another cold cap where the cap is no longer cold. And currently there are actually machines that can maintain the temperature and therefore deliver continuous cooling of the scalp. And this is usually administered before, during, and after the chemotherapy. It usually starts about 30 minutes before the chemotherapy goes in. And then during the duration of the chemotherapy, and after the chemotherapy, it continues for somewhere between 30 to 90 minutes, depending on the type of chemotherapy that you get. And it has actually been shown to be successful in decreasing chemotherapy-induced hair loss with varying degrees of success depending on the chemotherapy regimen. It can be as low as 10 to 20% for certain types of chemotherapy and as high as 80% for others. So how does it actually work? If you look at the flow chart on the right, you would see that it essentially decreases the temperature of your scalp. And when it is cold, your blood vessels will become smaller. And with this, there is less blood flow going to the hair follicles. What actually causes your hair to fall off? It is the side effect of the chemotherapy, because chemotherapy kills off cells. And this also injures the hair follicles, and that causes the hair to therefore fall off. And by decreasing the blood flow to the scalp, it hopefully decreases the damage to the hair follicles and therefore decrease the side effect of hair loss on these hair follicles. So the picture you see here would be a scalp cooling machine. This is available at our institution in the National University Cancer Institute, Singapore, and in quite a few of the private oncology centers. It is one of a few brands of machines that are out there. We have actually done a pilot study in our hospital over the last 1.5 to 2 years. And when we first brought it into Singapore, we weren't sure whether it will be suitable because a lot of the previous studies were done in Caucasian countries. But actually, surprisingly, it was very well tolerated among our patient population. And I would say more than 90% of patients told us that they found it comfortable. It's not too cold. And they were able to finish up the chemotherapy, the scalp cooling during the duration of it. Of course, like I mentioned, hair preservation is more successful for some chemotherapy compared to others, particularly weekly taxanes. They do very, very well. But we have had less success in anthracycline-based chemotherapy like doxorubicin. In those patients, we tend to see more hair loss. And in terms of the hair retention, it would be less. However, we have had some patients who have continued their scalp cooling through the hair loss, and they anecdotally tell us that their hair regrowth has been faster, but this has not been validated in the studies. There are studies that are ongoing for this. And I think it's important, of course, to also know that regardless of the administration of scalp cooling, there is some degree of hair loss that would be expected. So don't go into scalp cooling thinking that, oh, I'm not going to lose any hair at all. I think even we have some hair follicle growth and regrowth cycles, and there is some degree of scalp cooling expected, but a lot of patients who have had success may tell us that it doesn't drop to an extent where they feel they need a wig or they need to cover up. There is thinning, so they still feel encouraged doing it. Whether or not each patient is suitable, I think at the end of the day, it's still a discussion to have with the oncologist. And if it's something you're interested in, do check with your oncologist to see whether this is something that could be potentially an option for yourself. And this currently doesn't only apply to breast cancer patients, it can be applied to other patients who are undergoing chemotherapy also. I think the second thing we wanted to talk about today is, I think there may be many of you who are breast cancer survivors, or some of you who are still fighting the breast cancer, and you may feel that sometimes your treatment options may be limited. And we're here to also want to encourage you that there are a lot of new treatments that are coming up, and do not lose hope that this is the end of the road, because a lot of treatment that even Namsoon spoke about today, Trastuzumab, Herceptin, TDM1, CDK4/6 inhibitors, a lot of these treatments were trial drugs just 5 years ago, and these treatments have become the standard treatment that we use today. Immunotherapy was not FDA approved until last year. So a lot of these clinical trials have given hope to patients. And I'd like to bring you through the stages of clinical trials that are out there. There is the preclinical stage where, these drugs are being tested in cell lines, these drugs are being tested in animal models, and they have been proven to work in the laboratory setting and very promising in terms of their effects. That's when, we would move a new drug onto what we call the phase 1 setting. This is a first-in-man setting. Usually these drugs are given in small populations of patients where we are trying to find, number one, the correct dose that we should be giving to patients, balancing its efficacy versus the side effect profile that you may have. At this point of time, usually the patients are very, very closely monitored. We can see them up to once to twice a week if required. And sometimes they need to be admitted initially because of safety reasons, just for monitoring. So a lot of patients feel very scared when they go onto a phase 1 study. They say, wow, you know, this drug has not been tested in people before. Is it very, very risky? You know, we reassure them and we tell them, yes, there is a certain amount of risk involved. We cannot deny that. But, you know, we watch you very closely. We monitor you very closely. And you may not be the first person in the world who's doing this. And a lot of times, a lot of these drugs may have been used in other cancers or other circumstances, but now are being applied to breast cancer. So it may not be a completely new drug either. But this is usually done in small numbers of patients. I would say maybe in tens and dozens. Subsequently, if again you show that there is good safety profile and it's safe and tolerable, and it is also showing signs that it works well, we would then move on to a phase 2, where, you know, now hundreds of patients are usually enrolled in this study. They usually have more confidence that it's going to work. And this is basically finding preliminary data to show that it works well. And usually at this point of time, the FDA would start to review the data, and then it would go on to a phase 3 setting where they usually involve hundreds to thousands of patients to prove definitively that this drug is definitely a good option. In the phase 3 setting, the drug is also usually compared to another drug. For example, what we usually use in, for example, hormone receptor positive breast cancer patients. If I were to treat them with just hormone tablets alone versus hormone tablets plus a new treatment, is it better? And that's usually happening in the phase 3 setting. After the phase 3 setting, if it's successful, the drug will be FDA approved. It may take some time for the drug to come to Singapore. It may be approved in certain countries earlier than others. But there is always an ongoing phase 4 study where the company is always monitoring for safety. And if there are any new safety signals, all physicians are then updated about it so that they can share that with their patients. So you can see within our institution that there is a very good rising trend of trials, mainly because there is just so much going on in research these days and so much drugs that are being pushed up because we understand so much more about cancer compared to a decade ago. And a lot of these drugs are actually drugs that eventually may make it to the market. You can see here that the accumulated numbers has, you know, gone from somewhere in the 30s all the way now we take on about almost 200 studies at our center. And in fact, in our institution, we also have a special dedicated unit called the Developmental Therapeutics Unit, where we look at new drugs that are being offered to patients. This could be new drugs combined with old drugs. This could be new drugs, old drugs that are being repurposed to be used in new types of cancers. There are dedicated units. We have a dedicated clinic for our patients, where it's all consultant run. We have inpatient beds. There are specific beds that are ring fenced for trial patients. And we have dedicated specialized coordinators that act as contact points. And a lot of times, all these drugs, because we are monitoring you continuously, we also work with the other institutions around in A-STAR and NUS to ensure that these drugs are safe for you. So how do you find out more? A lot of cancer centers in Singapore, both in the private and public sector, do offer the clinical trial option. In the public sectors, NUH, NCC at SingHealth and Tan Tock Seng Hospital would offer that. And in private setting, centers like OncoCare, PCC, ICON, and soon Curie Oncology will also offer trials if needed. I think the person who would know best about what works for you would be with your oncologist, because he or she would understand your cancer the best. And he or she will be able to contact the other doctors who may have what they feel is a suitable trial for you. There are websites that you can Google, find out more on from individual cancer centers or some cancer networks like the American Cancer Network, the Western Australian Cancer Network, that you may be able to find out whether there are trials available for you. Of course, every trial that is done is registered into a global trial registry, and you could try to filter some of these trials and see if they're suitable for your type of cancer. But more recently, there are actually these trial matching platforms that are out there now to try and help patients find the correct trial for them, of which OncoShot is one of them. That's a local endeavor, and I think it is very good for local patients if you're trying to look for trials within your region. There are also others available in other countries like Trajectory, Molecular Match, which uses some form of molecular data that we may have gotten from your type of cancer. So these are all new options that may actually help you find the correct study for you that may be most suitable for you. And I encourage you to look forward and see whether these are options for you.
Thank you very much, Jolene. So I think you actually explored a topic in terms of for scalp cooling, which is actually very important and relevant for many of our patients that we see in clinic. It's a common question. I've also seen patients who do not want chemo because of the concern of hair loss as well. So the fact that we do have options to address these side effects, is really a good development to have these days. I would now like to just introduce Samantha. But before I get into that, I want to point out two scenarios, or rather two actual submissions of patients at the point of registration, which was actually quite telling in terms of the emotional and psychological concerns that patients may actually have because of a cancer diagnosis. So the first was actually that of a patient who's taking care of an elderly 70-year-old lady with advanced breast cancer. And this caregiver expressed that she was under a lot of emotional and psychological stress in terms of managing the elderly mother. And they wanted to look out for potential services or options that could help them in this journey where they're taking care of a loved one with breast cancer. The second was a patient who is about 45 years old with an early stage HER2 positive breast cancer. And as we know, typically the treatment for early stage breast cancer after surgery is a rather prolonged one, where patients may have up to 1 year of treatment with HER2-directed therapy with chemotherapy in between as well. And one of the questions was, how do I go on from here? Who can I reach out to for support? Because it's been a hard journey so far. So I'd like to share our link with the Breast Cancer Foundation that has evolved recently, where we're introduced to some of the activities they have done. And I feel that Breast Cancer Foundation has been doing a lot of things, and we'd really like to share the work and the services that they're providing with us today. So I'd like to introduce Samantha Sia, the General Manager of the BCF, to bring us through some of the useful services that patients can access today. Thank you, Samantha.
Hi, thank you very much, and welcome everyone, and good afternoon. Or rather, it's still good morning until the next 9 minutes. I just wanted to share with you what we've been working hard on in Singapore, and we want to continue to provide extra support for those who are going through this journey. Just note that you are not alone, and I'm just going to share with you what we do. Okay, we've been around for 23 years, and we really want to look at how we can partner with so many community partners out there, with the doctors and with yourselves, how we can reduce the impact of breast cancer, because this journey is not alone. There are many people that are impacted through this journey. What do we do? Our main focus is that once you've been diagnosed, we want to make sure that you are supported all the way through, and we want to ensure that we are able to support you emotionally. We do have a group of women, volunteer befrienders, who are there to help you walk through this journey. We have Dr. Wong and Dr. Lim that have shared with you all the support you can get from the doctors and the nurses in the medical front. But what happens when you come home? So are you in this journey alone? No, we do have a lot of our breast cancer survivors who are willing to walk that journey with you. And when you contact us, we are able to match you according to your type of cancer. If you're the caregiver, you can share with us and we will match accordingly. So this is a journey that we are wanting to walk with you, because we've found that a lot of our breast cancer members found that when they were diagnosed, they felt that they were all alone in this journey. Nobody understood them. And so we are here to help you in whatever way. We also have a couple of pillars that we can talk to you on. We've shared with you about our befriending service. We also have a support group. Now we have 4 types. One is the English support group, where we cater to those who are more comfortable in the English environment. The second is our Mandarin support group. The third is a caregiver support group, and this we also have a men support group because we do know the men play a very, very important role in this. And just know that the men out there, you are not alone as well. We have men that they have gone through this journey and can understand what you are going through. And we've just formed, just recently, a young women's support group because, like Dr. Wong and Dr. Jolene have said earlier, this group is starting to come up, and the people the young women that are being affected, their cancer tends to be a little bit more aggressive. So we have a support group for them, and they then that tends to be more targeted, the types of talks, the types of workshops, the monthly support group, it tends to be more targeted towards their needs, because their needs are at a different stage of their life. They have different issues such as career, family issues, fertility issues, marriage issues. These are different issues that maybe a woman who has been diagnosed a little bit later in her life, those are not as pressing because it depends on when you are diagnosed. We also do conduct midday talks, of which it is done usually according to different topics. It could be something related to diet. It could be related something to hairstyling, because Dr. Lim has said it is a major issue, the hair issue. So as such, we do this, and now we're actually online as well. So if, because of the current COVID situation, all our support groups are all online, so it's free to join, okay? We do, like I shared earlier, the Young Women's Support Group. So this is something that has met many, many needs. And you know, when you're in this group, you will find that you are matched with a mentor who is the same age as you and who is now currently mentoring other young women as well. We also will do an education program, because once you're diagnosed, there's a lot of questions like, how do I survive this? What do I do? So we actually run two programs, one for breast cancer survivors and one for caregivers and their families. So it's what to expect. And these are tips like what type of, what works in an everyday setting when you are away from the hospital. So do check our website, because we will update when we run these programs. And we have different trainers that come in, and they come in and share their expertise. It could be from a psychologist's point of view, a doctor's point of view, a nursing point of view, a pharmacist's point of view, and as well as an exercise point of view. So there's many, many inputs so that you get a holistic view of how you can walk this journey. We also have this program here, which basically talks about how we can recuperate together. This program is only exclusively for breast cancer survivors. And we have a variety of programs, as you have seen in the earlier slides by Dr. Wong and Dr. Lim. Some of the side effects are numbness of the fingers, swelling of the hands, and as such, we want to encourage the patients to realize that there is life after cancer. It does carry on, and as such, we want to ensure that you are in the community of women who are going through what you are understand what you're going through. So as such, we have activities such as crochet. Now this actually helps the numbness. When you do the crocheting, it kind of prevents the numbness from developing. We've got sewing classes. We've also got things like dragon boating. Now dragon boating, you may say, oh my goodness, this is so active. But actually what we've found is that this has really helped a lot of patients who have the lymphoma after surgery. And we have found that these, when you do the action itself, and from one of the clinical studies that was done by a Canadian surgeon many years ago, they found that this is one of the best activities that actually helps improve the health of the patient, plus prevents the lymphoma from occurring in the arms. So we have other activities, this is Qigong, Zumba, art. I mean, these are a variety that a woman can choose from. And of course, it then creates that community for the women to know that they're not alone in this journey. So some of the classes I've seen with some of the members is that the woman comes in, and while she's doing her Zumba, she literally takes her wig off, and she feels comfortable in that environment. So do know that there's a place for you to come and just totally be yourself, and nobody is going to say anything. We have this program known as Rebuilding a Positive Image, like what Dr. Lim has said earlier. This is big, really, really big. The loss of hair has had a major impact on our lives. And we do have this program, and this is actually a free program, but we do request that you have to be members of Breast Cancer Foundation, which is free anyway. And what we do is that we do have a wellness room where you can actually sit with our programs people and say, share with them your emotional needs. And it's a one-to-one service, and it is an emotional outlet for you. Yeah, and so we do provide this complimentary service, but do make appointments with us because we want to make sure that we reserve the space for you. And we do have this program here. Now, this is for the ladies who have had a mastectomy, but did not do the reconstructive plastic surgery work. So this is a prosthetic bra service that we have. And this is for CHAS card holders, and which they will have to go through the restructured hospitals. And you have to reach out to your medical social worker, and they will just apply accordingly. Yeah, so these are some of the key programs, and I will pass the section back to, and these are all our contact details. Yeah, so if you need to contact us, please call us.
Thank you, Samantha. So I really appreciate the work that the Breast Cancer Foundation is doing, and this is quite clearly an important role for organizations such as the PCF, supporting our patients and caregivers in their journey. I will also be sharing these contact details hotline separately in the emails post-event so that patients and caregivers can actually have that with them if they ever need the information. So just to clarify, I think there was a mention of lymphoma, but you probably meant lymphedema.
Yeah, sorry, yes, lymphedema, I'm sorry. Yeah,
no
sorry.
So that's a minor thing. So I would, we are running out of time now. So what I would probably want to do is, I have a summary that I'd like to share with our participants. And after that, maybe for those of you who still want to ask us some questions, we can set aside another 5 to 10 minutes just to address that. We have great interest and a lot of questions that have been coming in, and it's going to be hard to address all of them. So what we'll probably try to do is that we would take some of these broad ideas and try to clarify them. And for very specific ones, we'll probably get back to you separately and advise you on how you can probably discuss this with your own physician to get a very personalized recommendation for how you can move forward. So just give me a second and I will share my screen. Okay. Yep, so I think there are a few take-home messages that I would just like to emphasize at the end of this presentation. The contents of today's talks were largely, not just for an individual cancer patient or survivor, but it's also meant to speak to members of the public and caregivers. And so from a very broad perspective, what I think I would want to say is that at least for those of you who do not have cancer, but are women and you fall within the age groups, it will be very important to stay informed of the breast cancer screening guidelines in your own countries. It's not just in Singapore, but we have a lot of participants from the region as well. So if there are regular screening programs, please make sure that you're actually following up with those things, because it is quite important in picking up cancers that may present early. There was good discussion from Dr. Wong Nan Soon's presentation, as well as Dr. Jolene's discussion about innovative treatment, that today, more and more, how we manage cancer is going to be going to evolve in a very personalized manner. We know that there are now gene assays to look at your personalized risk and benefit that you may get from chemotherapy after surgery. And along those lines, you find that understanding the profile of your tumors can actually open up treatment options in a deeper manner as well. So this is an important discussion that our patients should have with their physicians in terms of how genomics or personalized medicine plays a part in their treatment options. The other thing that was very clearly highlighted by Dr. Jolene in her presentation was that we are truly living in the age of innovation. A lot of the developments that we have seen have happened very recently within the last decade, maybe within even the last 5 years, with new therapies that are really changing outcomes for many patients. Timely access to some of these innovative therapies may be an option for some of our patients in Singapore. And it's actually quite helpful for you to have that discussion with your oncologist in terms of not just what your standard therapies are, but what your clinical trial options may be in Singapore. And last but not least, I think we just had this presentation by Samantha where she's really highlighted that, beyond what we can get in the hospitals or clinics for our cancer care, there are actually a lot of community support services that are available at the level of the patient and their families, and they can really benefit from reaching out to these community support services and taking care of themselves, not just physically, but emotionally and mentally as well. So that would be really, my key take-home messages from the presentations from our speakers. And at this point in time, we've kind of hit our 12 o'clock mark, but if some of you are happy, we can actually address some of the questions that have been raised. I will probably not go into the very detailed or specific questions, but we might set aside maybe just 10 minutes for the benefit of our participants to just address some broad questions. Is that okay with everyone? Okay. Maybe Dr. Wong, there were some questions about how do we perform surveillance for breast cancer, and how as a patient they can take the right steps to pick up recurrence of breast cancer. A particular question that I also had was, is there a role for tests such as a PET-CT in monitoring for breast cancer recurrence? Maybe you could help with that question.
Okay, so I think for surveillance, there are various forms of surveillance scenarios. So I guess the question pertains to a patient who has had surgery, has completed adjuvant therapy, and we're monitoring for signs of recurrence. So the usual type of follow-up we perform would be history, physical examination once every 3 months in the first 2 years. And thereafter, we do that every 6 months until year 5, where we do that annually. So in terms of imaging, the only recommended surveillance is actually mammography, supplemented by ultrasound if the need arises. Of course, there's a lot of questions about, is there a need to do regular PET-CT scan, regular CT scan or MRIs? So that has to be individualized based on the patient's symptoms, and also based on the baseline PET-CT findings at staging. For example, patients who had sort of equivocal or doubtful spots in the lungs or liver, where we give the benefit of the doubt and we proceed with adjuvant therapy. And at the end of adjuvant therapy, we will want to repeat the scan to make sure that those spots have remained the same or have gone away. So I think the simple answer is that there is a system for following up patients after completion of surgery and adjuvant therapy. It involves simple procedures like physical examination, history taking, and yearly mammography. And everything else has to be individualized according to the patient's background.
Thank you, Dr. Wong. One of the questions that was also asked in the Q&A chat was with regards to, let me just see that, patient with an, maybe I'll just make it a bit broader. Are there any delays, potential delays in, for example, adjuvant chemotherapy that may be required? Maybe the way to answer this question, Jolene, is typically if chemotherapy is recommended, when should a patient receive it within?
I think that in patients who have already had surgery, we generally recommend chemotherapy within the first 6 to 8 weeks and hopefully not past the 12-week mark. Sometimes for some patients it's inevitable. Usual reasons would be things like when the wound is not healing well, or when the patient may have experienced another medical condition during this period of time, and that may inevitably delay the start of chemotherapy. At the end of the day, I think the most important thing to remember is that safety is paramount. So at the end of the day, we do not want to start chemotherapy when your wound is not well healed, and that may increase the risk of the wound worsening, because chemotherapy can bring down your immune system and delay wound healing. So I always tell my patients, safety is number one. Let's not rush into chemotherapy. If we need to delay it slightly, that's okay, because we need to make sure that the wound heals properly. Or if you had, for example, for some unfortunate patients, experience another problem like a stroke or a heart attack in the peri-operative period, then we definitely do not want to risk your heart further or your neurological function further. And sometimes there are certain options we can play around with while waiting for suitability to start your chemotherapy. Sometimes this may mean starting your hormonal therapy first. Sometimes it may mean doing the radiation first, or sometimes it may mean starting the anti-HER2 treatment first. So these are definitely options that are available if for some reason we're not able to start the chemotherapy early.
Okay, thank you, Jolene. There were two questions that were centered around what are the mechanisms for breast cancer formation. And I think what I'll do is, from the OncoShort team back end, maybe we'll prepare a blog article or something, because it's not a very straightforward question to answer. And we're trying to keep it simple, and we'll share that link with you, all right? So don't worry about that. Aside from that, I'm just looking through the last few questions. Someone had asked whether the the webinar we made available. Yes, we've recorded the webinar for your benefit, and we'll be sending the details to you post-event as well, so not to worry about that. I would think that that would largely be, the scope of questions that have been asked from the registration and over the course of this presentation. I would just like to say a big thank you to our panel of speakers, Dr. Wong, Dr. Jolene, and Samantha. We had a very informative session. We covered a lot of ground today on the potential treatment options and the new innovations that are happening in breast cancer management. I think our patients would have also learned a lot during today's course of session. Let's not stop at this. So if there's any room for us to help you with certain gaps of information or queries that you might have, please feel free to go back to the registration page for the webinar. You can ask us more questions, and we'll try to get back to you. I think this is an ongoing discussion, and it's really quite important to keep our community of breast cancer patients and caregivers and survivors very much informed of what's happening today. So I want to say a big thank you to everyone. So thank you, and have a great day ahead. Have a great weekend ahead. All the best.
Thank you.
Bye-bye.
Thank you. Bye.
Bye.